Elective orthopedic surgical pathways are operating under immense physical constraints. The volume of patients entering the system vastly exceeds the physical capacity of theaters, pre-assessment clinics, and available surgeons to process them. System leaders often view patient experience tools and shared decision-making models as soft interventions, exercises in patient satisfaction that do nothing to alleviate this hard pipeline bottleneck. An updated clinical evaluation of Torbay charts, spanning 216 patients and 55 clinician evaluations across multiple sites, challenges that assumption with hard data. Structured visual shared decision-making acts as a highly effective operational intervention. It actively unburdens surgical lists by changing how patients navigate their own care. First, the tool achieved a 92% resolution rate in pre-consultation patient indecision. Second, among patients who entered the clinic actively expecting to undergo surgery, 33.9% chose to downgrade to conservative, non-operative care after the consultation. Systemically, this shift compounds rapidly, projecting annual savings of anywhere from £378,000 under the most conservative models up to £1.66 million. These pathway savings raise an immediate clinical question. Are these numbers the result of artificially suppressing access to care, or are they the byproduct of strict clinical alignment between the patient's actual disease state and their chosen treatment? To isolate specific behaviors, this Sankey diagram tracks 56 patients anticipating surgery. Following a structured visual consultation, their intent fractures. 19 individuals, 33.9%, voluntarily diverted to non-operative management. Conversely, exactly 0 patients were escalated from a non-operative preference to surgery. The intervention acts as a one-way operational valve. It actively reduces surgical demand without inducing it in patients who do not require it. Then there is the operational drag of indecision. Undecided patients often consume multiple follow-up appointments, holding space on the list without moving forward. In the most recent cohort of 46 patients, 25 arrived in severe decisional conflict, unable to choose between operative and non-operative care. Following the structured consultation, 23 of those 25 patients immediately moved to a definitive pathway choice. Achieving a 92% resolution rate in a single session recaptures outpatient capacity at the point of care, eliminating circular, low-value follow-up appointments. This brings us to the primary clinical objection. How can we be certain the tool isn't deterring high-need patients from the surgery they actually require? The evaluation measured patient condition using the Oxford score, an objective metric for assessing joint function, where lower scores indicate worse symptoms. This scatter plot maps final treatment choices against Oxford severity scores. The surgical cluster averages a severe 9.7, confirming high clinical need. In contrast, the non-surgical cluster averages 26.0, indicating higher joint function. The correlation is a strong negative 0.83. Patients are not being blindly deterred from theaters. They are making informed treatment choices that tightly align with the mathematical reality of their disease severity. We have to ask why this specific clinical alignment occurs so reliably with this intervention. Patient experience data provides the answer. Across core shared decision-making domains, the tool averages 4.38 out of 5, peaking at 4.43 for feeling involved. Qualitative feedback shows visual disease mapping removes abstract medical jargon. Patients noted that physically seeing their position on a pathway gave them unprecedented clarity. This creates behavioral activation. By seeing the mechanics of their condition, patients transition from passive recipients into active participants who recognize the specific need for physical conditioning and gym work. True patient empowerment does not drive up demand for high-cost interventions. Providing clear, visual context acts as the primary mechanism to relieve surgical desire. But why does this matter? We can now translate these psychological shifts back into macro-level health system economics. Applying the 8.8% diversion rate to 2,000 patients yields 176 avoided surgeries. Multiplied by the £9,450 procedural cost, annual savings reach £1.66 million. Even under a highly conservative 2% diversion scenario, the intervention still secures £378,000 in saved costs. The impact extends beyond raw financial capital. Diverting these patients actively releases downstream physical resources, freeing up pre-assessment beds, opening outpatient clinic slots, and returning valuable theater time. Deploying structured visual decision-making tools is a self-funding strategy. It precisely aligns patient autonomy with the operational realities of elective recovery.